All right.
I've got a few.
Awesome.
You guys see my screen?
Yep.
So, Howard, I think you in particular hopefully will like this one. This is one I just saw this morning, but it brought to mind this recent article that was, or this image in medicine that was in the new radiology cardiothoracic imaging. Did you guys see this? This
No.
particular thing? This is kind of cool. So the intralobular gradient as seen in re-expansion edema, and I think we've seen this before, and they've kind of they've nicely described this, how even within secondary lobules, you can have dependent layering of fluid, like edema. And they're trying to say how it, kind of looks like this Chinese landscape painting. But, we've talked about layering edema on, dependent edema layering on a macroscopic scale, but not really on an individual lobular scale. But I thought this was a pretty, you can see what they're talking about here, right? Things level, like layering with the level in the secondary lobules.
In the dependent portion of them.
Yeah, so this guy came in yesterday, and he's obviously got a big heart. He's got some cardiac issues and has some stuff in both lower lobes. And on the CT that was done overnight, this is not re-expansion edema, but I'm wondering what you guys think about some of these areas looking somewhat familiar, like here, some of it just starting to layer a little bit more. Now, some of these areas are a little bit more confluent, and this guy certainly has some component of volume overload. Some of these airways were a little thick, so there's a question of whether he's got some secretions here, whether he's aspirating or not clearing his secretions as well. But you would agree that some of this, at least in part, looks like edema, and it kind of has a similar appearance, even if it's not re-expansion edema.
Yeah, especially in that left lower lobe up a little higher. You had really nice right there. Yeah, that's a really nice example.
So yeah, it's kind of cool because we've seen this before. I liked how they just described it as like an intralobular gradient. And this guy,
I haven't thought about that before, but now that you mention it, I'll keep my eye out for that phenomenon.
Yeah, right. Because I think in his case, he's just he's very tenuous given how big his heart is. And I know, Howard, you've always talked about like the stress failure of the capillary membranes when you get an acute rise in hydrostatic pressure. But I just thought that was a cool little image. So this one, I'm curious what you guys think. Now, the radiograph from a few years ago, 16-year-old, healthy. The only symptom she had at a physical was that she had a right cervical lymph node that was reportedly enlarging and slightly more firm, but very athletic, active in athletics, no B symptoms. So you can see the radiograph at the time, she does have lymphadenopathy, right paratracheal, AP window here. I think there was some subcarinal lymphadenopathy as well. Kind of not really all that obvious, maybe a little increased opacity here. But the reason I show this, because I'm just curious, what do you guys think in terms of just looking at the lymphadenopathy, how high would you put sarcoid on the differential?
It'd be pretty high, especially if she had no symptoms.
Yeah, very high, based on what I see there.
Yeah. Now, so because make a long story short, cervical node biopsy ended up being Hodgkin's lymphoma. And it was classical Hodgkin lymphoma at the time of this. And I just saw a recent follow-up radiograph, and her lymphadenopathy in her chest is gone too. So she's in remission now. But I was a little bit nervous about looking at this because I thought maybe the fact that there's so much more in the anterior mediastinum would make you argue against sarcoid. But other than that,
so that's thymus.
Yeah, you're right.
Any chance it was a sarcoid reaction to the lymphoma, or did they actually biopsy the mediastinal node too?
They never did, and that was going to be my next question too. Like not to throw two diagnoses in there, but yeah, I mean, because looking at this on its own, like you said, especially if they're asymptomatic, you've got the typical distribution with symmetric bilateral hilar, subcarinal, paratracheal, and then you've got some nodularity to the thymus. But I was a little surprised when I saw that.
I agree.
Was there extension down? Because I mean, the classical teaching is that Hodgkin spreads from node station to node station, right?
Right.
If you had a cervical node, you'd expect there to be sort of high mediastinal, superclose. I'm not seeing much there. Maybe a one node.
Not much. Maybe.
I guess it could not cause a big node, but still have reached.
Right. Like there are some cervical nodes. You're right. Maybe it just extended down. Yeah, and there's some posterior
for sure
cervical nodes, but yeah, no, but that was my thought too, Jeff. Was there any chance it could be a sarcoid-like reaction in addition to Hodgkin's lymphoma? Because they never did biopsy anything in the chest since they got a diagnosis from the neck. But I think it just serves as a reminder, we oftentimes can be confident of sarcoid, but I guess not in every case, especially like this. So that was just kind of a, that was a little interesting. Let's see, show you this. So I don't have a chest radiograph. I do have a spine radiograph, and I will let you guys look at this, and it's a nice eye test.
There's something medial to the aortic arch. It looks like pushing the trachea over.
Yeah, right here, good. And see there's a little calcium there. Now these fusion rods, he had a horrible motorcycle crash 40 years ago. And you can see on the lateral too, corresponding exactly to what you were saying, Jeff, right there. So curvilinear calcification posterior to the trachea. And so no surprise in the setting of trauma, here you go. Here's your old healed traumatic pseudoaneurysm, and it's exerting mass effect. So this is one of the guys that, in the pre-CT era ended up with a pseudoaneurysm or traumatic aortic injury at the isthmus that healed and now has a pseudoaneurysm. And so this was incidentally discovered on one of the spine CTs they were doing. And so that's what prompted this CTA. But I thought the spine radiograph was kind of fun just as a good eye test for this, but they're not going to do anything because he's asymptomatic at this time. And if they did any sort of endovascular repair, they might have to do a carotid to subclavian bypass graft. So they're just going to watch.
Yeah.
So
that's a nice one.
Classic, an Ant Mini.
It's interesting that it's medial. It's kind of involves that medial aorta.
Yeah. Yeah, that it's a little bit. You're right. It's a little bit more like medial than the ones we typically, think about. But
yeah.
All right. Let's see. Oh, this is a very interesting one. So this guy was transferred in with a history of endobronchial tumor. He's trached. So he is a drug user, had an overdose a few years ago, ended up with a prolonged intubation, subglottic stenosis, chronic trach. And I think he's still an alcoholic, is not using any other drugs, but then for some reason at the outside hospital got a CT, and this is the one that he had. And the outside, they saw that there's some plugging in the airways here on the right side, some mucus impaction throughout. And then they saw this in the right mainstem bronchus and thought it was a calcified mass. And at the outside, they actually did a transbronchial biopsy and got squamous metaplasia. So they transferred him here with the suspicion that he had an obstructing tumor. Now I'll show you, you can look at this and see that it doesn't look like a typical tumor. There's some weird curvilinear higher attenuation thing here. And I'll show you the follow-up CT that we did here. And this is before they do a repeat bronchoscopy. And now you can see it's a lot of the granulation tissue and everything else has decreased. And it looks like, the first guess that we had was it a wire or something, or a piece of metal? It's pretty thick. And then, but when you window it, and you can see that it almost looks like there's a little, like you see that right there. It almost looks like it's hollow in the center. Any guesses as to what this is?
It looks like like cartilage, like curved like a ring of a trachea or something.
Yeah, it kind of does, right? But like, look at this. I mean, here it looks almost like a suture needle.
Yeah. Wow. Oh, it's that big. It's that big.
Yeah.
Huh.
It's
but it's hollow in the middle.
It is hollow in the middle. And the other thing is too, it's not metal because you don't see it on the radiograph. And if there were Yeah, and it's more like you're saying, like cartilage or bone. And so this is what it is. It was a chicken bone. So like a rib from a chicken. And so apparently he eats fried chicken all the time when he's, and probably just aspirated this. So, but it was not, not a tumor as they originally thought on the outside. But yeah, I thought the coronal especially is kind of cool, just how big this thing is.
Yeah.
So, and then and the other thing was too, that they thought it was just gonna be granulation tissue. They did a little bit of biopsy here, and actually there was an active actinomyces infection in this area as well. So they grew, one of the cultures from the bronch grew actinomyces. But foreign body, chicken rib, we can add that to our collection of foreign bodies. And then this one, is a long and involved case, but it's kind of an interesting one because this is along the anterior mediastinal mass differential. When we were talking about lymphoma earlier, this is a 67-year-old man who presented with this anterior mediastinal lesion, and you could see maybe a couple discrete soft tissue nodules or lymph nodes here.
Now,
And
before you go on, can you just go back up there, Travis, 1 second?
yeah.
Is the pleura, mediastinal pleura around it, thick? Yeah, there's something wrong. I don't like that.
Yeah, either, right, good question. Yeah, is it a little atelectatic lung, or is there focal pleural?
Or is it pleural in tumor?
Some of this is atelectasis. Now the rest of it, I don't know, because there's not, there's not a, right here. Now you're exactly right. There's subtle findings there. So what was that making you think about?
I'm just thinking of a pleural membrane tumor extension in a case like this.
Yeah. Well, long story short, they did a PET, they did a biopsy, and this PET was a little bit later, and you can see some of these have enlarged. And I guess this helps answer that question. It looks like it's probably just a little linear atelectasis there. But this actually turned out to be melanoma.
Yeah.
And he had no primary. So this was presumed as metastatic melanoma from unknown primary involving the anterior mediastinum, because they thought it was going to be a thymic neoplasm, and went in and did a median sternotomy and did what they thought was going to be a thymectomy. And the other reason I show this is just because he, as a result, no surprise, they had to sacrifice his left phrenic nerve when they did the surgery. But I'll show just you can see from the thumbnails, the elevation of the left hemidiaphragm. And this was several years ago, but you can see now, and I know how David in particular always talks about, and how they published that, the paper from University of Washington on thickness of the cruce. And you can see how the left cruce is thinned over time as it's chronically paralyzed left hemidiaphragm. But he's been on a PD-1 inhibitor and been doing quite well from his metastatic melanoma too. So that was an unexpected surprise from the anterior mediastinum, especially with no known primary.
Yeah, I saw one like that maybe a year ago, in which subcoronal lymph node enlargement was the only pathology, and it revealed metastatic melanoma. Seems to happen. I see that maybe once every, I don't know, every couple of years. Unexpected metastatic melanoma. Unknown primary.
I've got let's see, I was going to pull up the sniff test because I think this is just during, quiet respiration. There's really, there's maybe it moves a couple of millimeters, probably just secondarily from everything else moving. And then one of these is that looks like more forceful inhalation, still not really fixed. And then this one's probably, I can't even remember which one. That looks like, yeah, there's a little bit of paradoxical motion there on the sniff. But obviously it's a long-standing diaphragmatic paralysis. I think you don't even need the sniff when you have the CT and the radiograph findings.
Yeah.
All right, well, that's it for me, Jeff.
All right, great stuff. Howard, you ready?
Yep.
All righty.
Okay, I'll start with this one. Let's see. Okay, so this is a CTPA, and if we were reading this, we would just read this in the usual way. There is obviously greater opacification of the pulmonary artery, so it's a diagnostic exam, and there's no PE. Let me show you an interesting finding on the coronal. This isn't exactly how things transpired, but for fun, I'll show it to you this way. So what's interesting about this is you can see that they injected through a right PIC. You can see at the time the contrast started coming out and the scanning was done, where the PIC is, it has flipped up into jugular vein. Contrast comes out of it. It's still a diagnostic exam, but there is the PIC up there. Then I will show you that on the scout topogram that the PIC was in the proper position just a moment earlier. See it coming down like that. I'll make that up a bit so that you can see it coming down into that position. So it flipped up from the injection, the recoil, and then I'll show you a follow-up done just a little while later, where without any intervention at all, it's back in the proper place. So transient flip of the PIC up the jugular, and then blood flow just carried it back down again. So let's see if I still have, I'll show you an article in a moment. Have you guys seen that before? Maybe it's happened, we've never realized it.
I've seen it move, but I've not seen it move back. It's effectively a water rocket when they inject it at that rate.
Yeah, it just shot back up there, didn't it?
I guess,
Yeah.
it just flowed with the blood back down.
Yeah, because I think I've shown one, and I remember Jeff making the same comment before. Yeah, it's like letting go of a fire hose. It's got water flowing through it.
Yeah. So then one of my residents said, hey, did you see this patient that had radiographs? This isn't a current exam. And at the time he had lung edema. I don't know what the clinical situation was, but PA and lateral radiographs. On the PA, the PIC properly positioned. On the lateral, obtained. Same exam. Where is it? It's called up here somewhere, but it's not here. So it seems like when he pulled his arms up, it flipped up completely. It just has to be up here somewhere.
Some of it could just be in the subclavian vein that you're seeing there, but I agree, you don't see the tip anymore. I'm wondering if when you pull your arm up, do you essentially pull it further into the arm?
No, it usually moves down.
Well, yeah, that's a question. So he has an article about just usual movement of PICs. And this is an excerpt of an exam. So Jeff's right that usually if you compare arm abduction and adduction, so usually when they put them in, the arm is abducted, at least 90 degrees. Usually most of the ones that moved a bit moved down quarterly. So here is 61, 43 moved quarterly, 7 moved cephalad, 3 did not move. Mean distance, 2 centimeters. So go figure this case. I don't understand it at all. So they can move a bit, but that's downright weird. I don't know what to make of that.
I think I've seen this happen once too, and I don't know why it happens, because it should move down as you raise your arms. But it brings up a point of the obsession with the cavoatrial junction, how it's a moving target because arm position changes constantly from radiograph to radiograph, but also just during the day with these patients, and many of them still do things. So I think as long as it's roughly in the right place, it's probably okay. It's just with your arms down, you don't want it too low because they're soft and body temperature, and they flop around a little bit. So as long as it's not too long, I think with in the low, anywhere in the SVC is typically okay.
Yeah, so that brings up a question. My fellow and I were discussing this morning because she asked the question, like, do we call every time a pick has flipped, from a daily radiograph to the next one? And I used to. I admittedly now on just daily radiographs. And Jeff, I know you're not doing many daily ICU radiographs anymore, but because it's so common for them to just flip back down. I don't consider it really an emergent finding.
Yeah, I just put it in the report, unless this. Yeah, I mean.
Yeah, I think this is common.
One of the ways they get them down is they do a little saline injection to fire hydrant it back down, or fire hose it back into the right place.
Exactly. That's what they do. If it's flipped up, that's what they always start to do. So yesterday when I did a Google search, you can find a lot of comments on discussion groups involving the Society of Vascular Access. The folks that put these catheters in have a little community and they chat. And they describe this as quite commonly. And they talk about how they all see flip cases and they inject them and they flip back down again. And sometimes apparently when they flip back up, they say patients report a swishing sound when something's injected into it. And that's a clue that it might be in the jugular vein. It's kind of interesting discussions you can read about those folks talking about flipping picks. So I don't know what to make of this particular one. Went in the wrong direction. And I don't have a radiograph in follow-up, so I don't know what happened after that. So go figure about that. But the flip with the injection of contrast is something one can find case reports of. So that's kind of a known thing, one I showed you before. So this one is interesting too. I don't know the exact sequence of clinical findings, but this is a radiograph from the 27th of October, and there's nothing really to see on the radiograph at all. Even looking in retrospect, I can't really see anything. And then I saw that 2 days later, a CT was done, and I couldn't determine exactly whether it was done because the patient developed new symptoms or worsening symptoms. But take a look at this. So now we have, way up in the apex, we have this cavitary lesion. And you can see that it has kind of a bird's nest type appearance where there's less attenuation in the central portion compared to the peripheral portion with obvious cavitation. And what's also interesting to me is that we have regional interstitial edema in the sense that we have septal lines, and we even have peribronchial fluid cuffs of interstitial edema as well, and then some ill-defined ground glass opacity. So I'm not quite sure what's happening here, why there is some interstitial edema. Is it because there's just the intensity of inflammation? Is there something to do with lymphatics? I don't know why, but there's clearly that process and some interstitial edema as well. So here you have a nasty finding consistent with the necrotizing pneumonia. And then I will show you that on follow-up after treatment, and I'll show you the path in a moment. So this is, let me get the time right again. So here is 10:29 follow-up. Shows that all we have left now is a little cavitary lesion, a little cavitary space. Everything else looks great up there. And we just have that. So this is apparently by virtue of the culture of lavage fluid Pseudomonas. Isn't that interesting? So we have, oh, here's chest pain, vaping, chest pain up there, and that lesion, and this grew Pseudomonas. So I don't know what to make of that. Lots of neutrophils.
Was she on anything for, it said UC in remission. Was she on any TNF alpha inhibitor or anything that would have?
I don't think so. I don't, too sort of predisposed to a.
Yeah, just a more rapid or allowing it to evolve faster without much of an immune response. Can you go back to the radiograph again? I want to look at that apex. Like you said, it was. I didn't see anything, and no, but even in retrospect,
yeah, like anything.
it just looks like a little apical scar up there, like you typically see.
Yeah, even at a stretch, it's hard to even really see anything in there.
Yeah, I think your cursor was right over the hole in the cavity right there,
yeah.
but only in retrospect.
Yeah, because that is not exactly a small thing. Right there, sorry. I'm impressed by that. Sometimes apparently Pseudomonas can invade blood vessels and lead to in situ thrombosis, just like we associate with so-called vaso-invasive aspergillus. I think Pseudomonas is one of the bacteria that can sometimes do the same thing, even in non-immunosuppressed patients. But I don't know. It's an unusual location, but certainly necrotizing, rather bad. Do you have any theories about the interstitial edema? I'm just curious. Is it just...
I think it could be, localized inflammation, increased lymphatic drainage, and
maybe
have a lot around areas of infection. And actually, I think that can be a very helpful finding.
Yeah.
Got these shaggy margins. Like if you think of septic emboli, they're often kind of, especially when they're fresh, they're very shaggy around the edges, unlike, like say, a cavitary metastasis, which tends to be very clean.
Yeah, who knows? Maybe there's elaboration of, I don't know what, cytokines or other things that produce regional...
Then it was a lot of neutrophils.
Acute lung injury.
Inflammation going on.
Yeah, yeah, interesting.
That's
it. An interesting case overall.
Yeah.
And I don't know about the notion of the vaping. Could there have been contaminated vaping aerosol? But then you would think if there were bacteria in there, the heat of the vaping should have killed those Pseudomonas. So I don't know what to make of the whole case. It's just a weird presentation. Of what seems to be necrotizing pneumonia from Pseudomonas.
Nice case.
Yeah, interesting. Okay, those are mine, Jeff.
All right, I got a handful here. Let's see. We'll start less exciting. Go. So this is a patient. This is kind of a fun case to try to tie it all together on the radiograph. But this patient has this large mass in the left upper lung here, and you can see there's cavitation in it. But what's important is recognizing this high attenuation branching material in the lower lungs. And so this could be a neoplasm, of course, but with this big and that cavitation, there's mass effect on the trachea. With this, looks like barium, and indeed this was from an aspiration during a swallow study. So it might make you think, could this be an abscess? Alternatively, this could be a big neoplasm that's causing some esophageal dysmotility, but it's something we don't see a lot of on imaging. But this ended up being a really just polymicrobial abscess, but it was quite large. And you can see even here, Howard, there's a few septal lines around it. It may be big enough it's compressing the vein, but you even see I think you see some subpleural edema along the fissure as well. But it's kind of neat to see the barium in the lower lobes. Plus, you've got dilated airways, the wall thickening. So this is a chronic aspiration. So the presumption is this was aspiration leading to this lung abscess. But it's one of the larger abscesses I've ever seen. And typically don't like to, they wanted to, I think the primary team was sort of pushing for a bronchoscopy, but you don't like to open these things up. They can spill into the other lung. They can cause ARDS. So, and you can see it's deflecting the airways there. So in this setting and the timing of it, I can't remember, it popped up rather quickly. It was treated as an abscess and started to slowly resolve. But
what does it look like on the mediastinal window? Is it all low attenuation?
You can see it's very heterogeneous, but it's got a lot of liquid in it. And probably, what do you call it? Just a piece of dead lung floating around there. But yeah, you get multiple fluid levels and sort of a reactive pleuritis here. And some reactive lymph nodes. So I don't think they ever got a specific organism. I think it was polymicrobial, but it had a lot of neutrophils and stuff like that. All right, so here's another case of dense lungs, but this is a little even more exuberant. So this is a patient with long-standing kidney failure, and you can see almost looks like edema, but you'll notice the lungs almost look too dense, and almost you get what looks like a plaque along the right hemidiaphragm and some pleural thickening. So this was a portable, and then I have this was a cardiac CT, just a non-contrast, and you can see there's calcium in the wall of the left atrium. We'll come to the lungs in a second. So there's all this myocardial calcification, and then there's this exuberant calcification. And this was actually a pseudoplaque on the diaphragm. It's actually just calcified lung. So this is all from chronic renal failure, and it's just metastatic calcification. I did find an older, I think it was an abdominal CT or something, no, an older chest CT that shows that this is all there, been there for some time. But this is one of the more exuberant cases. You'll see some of it is more ground glassy looking, and then I'll put on the lung windows, and you see that more typical so-called acinar type ground glass nodules, sort of the reverse, and you get black septal lines around it. So, but this is one of the few cases I've seen this sort of dense calcification in the lungs like this. I don't know if you guys have ever seen anything. Go ahead.
What do the upper lobes look like? Because it's not, you're right. It's not like the typical or classic tumoral or metastatic pulmonary calcification you see with that apical gradient where you have more calcium in the upper lobes.
There's a denser band here around the rim.
Yeah.
But with the history, go ahead.
I saw a recent case that somebody showed me. It kind of looked like this, except it was more focal. And it's like, always wonder too if there's like some sort of acute insult that injured the lung in some of these areas, and is it a combination of tumoral calcinosis plus metastatic pulmonary calcification? Maybe so.
Yeah, it's hard to know.
I don't know.
Yeah, the gradient's kind of odd like this, and long-standing myocardial involvement as well. But that just was kind of interesting. All right, this is an interesting case. This is a little hardware case. So this patient has a defibrillator in one of the Medtronic ones here, and this is something I have not seen, but you can see there's all these little metal fragments around the sort of where the first rib and clavicle come together, and you can see the shock coil is unwinding, and it looks like over the years it actually fragmented, and these are shock coil. And so they actually removed this thing because it wasn't working anymore, and some of them seem to have even migrated, so these are presumably in the chest wall. And I'll put up the post removal radiograph because you can see that actually these were all embedded in they were either endothelialized or in the chest wall. Most of them stayed behind when they took it out. And the electrophysiologists weren't particularly concerned because when they did their evaluation, I think they do a venogram and all that. They have all their little tools. They can see that these were clearly embedded in the wall and weren't going anywhere. But it's right where you typically can see lead failure. And if you look carefully, there's actually a little fracture right here as well. Right, sort of kind of gets like a nutcracker effect between the first rib and clavicle. And there's motion there, whereas this is relatively fixed other than moving with the chest wall. And this, of course, is intravenous. But I've seen a break, but I don't think I've ever seen one start fragmenting like this.
Fragmenting and burrowing away from the vessel and ending up in the chest wall?
Yeah, it's weird.
Oh,
I have no other old imaging, so I don't know the progression of this. The patient must have had it put in somewhere else and showed up here, transferred their care here or something when it stopped working. But yeah, I mean, clearly this takes some time. This doesn't happen overnight. But yeah, these are all fragments of. You can see some of them came out with the leads, but some, like for example, that was left behind, and this guy was left behind, but these came out. So I presume they were going to replace it, but I didn't see any follow up at that time. But yeah, I've seen we've seen them dislodge, we've seen them snap, we've seen them those recalled ones that were present a few years ago, the Reata leads, but this was not a Reata lead. So I guess this location is one of the places that I always pay extra attention because that's where they fracture and where they, I guess in theory now they can also come apart.
I've never seen that before.
All right. Well, here's no, I haven't either. So now you have. So this is a pretty classic case of an abnormal chest radiograph with what looks like fibrosis in the right lung, but you'll see a couple of things. First of all, there's either pleural effusion or thickening. There's a clip here at the hilum, and then there's some dense calcium around the hilum. And the right lung is small, and there's some upper lobe volume loss. So, you think of maybe something congenital. We've shown cases of absent pulmonary arteries, but we can see there are vessels here. They're just very small. You could have an obstructing mass, surgery, or something like that. But this is something we've seen before, but I thought it was a nice.
Before you go on, Jeff, can you go back 1 second? I just want to look at something else.
Yeah.
Is there abnormal something related to the aortic arch around it and or in the lung? Because if there is, one would think maybe collaterals.
Oh, yeah.
Because I'm thinking of a certain thing, and I wonder if we're seeing potentially collateral vessels. Something's odd about that, and the aortic.
That's a good point.
It might be something. You'll see in a moment if there are abnormal vessels, mediastinal or otherwise there.
I'll pull up the CT next to it. Let's make this go away. So yeah, this is we'll look on the CT. We can see that. Yep, there you go, Howard. Look at that. So we see this large venous collateral. So this was a left side injection, and this is a superior intercostal vein that's as big as the aorta almost. So that's what this is here, and this fullness in there. And we see that the superior vena cava has this calcium in it, but is not receiving any contrast. The brachius valve vein stops. And then you can see there's a lot of large bronchial arteries coming off the aorta. And then as we go down, we have a beautiful smoke artifact in the pulmonary artery. It's not a thrombus. And you can see there's all this soft tissue around the mediastinum. There's not a lot of calcium in it, but there is some. And then you've got all these bronchial arterial collaterals, and then you've got retrograde flow through the intercostal vein down to the azygous vein, which is then going to go down and come back up the inferior vena cava into the right atrium. And then if you look at the lungs, you can see there's nodular thickening along the pleura, there's septal lines, there's bronchial cuffing, there's even some really tortuous vessels in here. So there's probably a lot of transpleural collaterals. So this is a case of fibrosing mediastinitis that's taken out most of the arterial and venous flow. The airways you can see are still open, a little bit narrowed. But it's effectively a very little functioning in that right lung. I don't have a VQ scan, but it would show very little perfusion to the right lung. There is some perfusion we see, but it's very reduced. And the venous drainage, you can see, is really absent. There's the inferior pulmonary vein comes in, and you don't see really any flow in there. If it is, it's a trickle. And same with the superior pulmonary vein. So presumably from old histoplasmosis, given the calcified node there, and there was no I know David would ask me about calcifications in the spleen. And then you can see there's a really nice so-called hot quadrate sign in the liver with a bunch of venous collaterals in the abdomen. And then the plexus of the spine as well. But yeah, good point about that collateral flow there, Howard.
Yeah. If you look at the lung windows, in the lung windows, do we even see signs of interstitial edema in the right lung in the form of septal lines or peribronchial fluid cuffs?
Yes. You see some septal lines, and then you can see the bronchial wall thickening, which is presumably from fluid in the walls or in the lymphatics. Because if the veins are out, the presumption is to me that the lymphatics are gone. At least the central lymphatics are out because they're even lower pressure. And that's the typical pattern, is you lose the lymphatics and veins first, followed by the arteries. And the airways, if they go, are the last to go because they're pretty rigid. And this is presumably some thrombus in the SVC here. Or so I've seen cases where the fibrosing tissue somehow invades, or it somehow gets into the SVC and causes just fibrotic tissue there. But then it tends to hang out there. So everything's going through this collateral pathway. So a case of fibrosing mediastinitis, presumably from histoplasmosis.
And Jeff, that lung parenchyma almost looked like lungs do when you have proximal interruption of the pulmonary artery.
And I think there's transpleural collateral. See how you can see along the fissure, it looks nodular, but it's kind of where the septa insert. So I suspect those are veins and lymphatic channels. And then you just see these very subtle vessels going to the pleural surface. And I think that's all transpleural collaterals at the septa, would be my guess.
Oh yeah, there was one image adjacent to a posterior arch of a rib where the intercostals were lots of vessels.
Yeah.
If you change to the window, there was one particular area, I can't remember where that was pretty a little bit higher. If you scroll higher even, there was some really dramatic, yeah, like there and about that.
Yeah.
That was spinal.
The more you look, yeah, right here.
Yeah, the more you look,
the more you'll find. Yeah. And then up top, all of these tortuous vessels. So this develops over many, many years and tends to slowly progress. So this was kind of a cool case. So this is a young woman in her 20s who presented with a palpable breast mass. And so she started with an ultrasound, and you can see that indeed there is this shadowing echogenic mass, but it's actually deep to the breast tissue and under the muscle. So and it was, at this point, it's pretty echogenic there and a lot of acoustic shadowing there. And this is where the palpable lesion was, but it's clearly subpectoral. So they, at this point, recommended getting a CT for a chest wall lesion, as opposed to doing a mammogram at that point, is what they did, appropriately so. There's a nice ultrasound. And you can see she's fairly muscular, and what we end up seeing right at the area is at 12 o'clock, right here, is a very nice example of an osteochondroma. It's got the common marrow space, intact, contiguous cortex, not much tissue around it, but you can see it's indenting on her pectoralis and would be a fairly firm but palpable lesion there. And I presume they're going to leave it alone at this point, unless there's a reason to it, because it doesn't cause a cosmetic defect or anything like that. But I've seen them poke into the lung. I don't recall seeing one poking out, or at least at this location. But it's an isolated osteochondroma, so she doesn't have multiple hereditary exostosis, and as far as I know, no family history.
Yeah.
So interesting, but not what I was expecting to see when I see palpable, breast mass, because usually they don't send them for a CT. But when I dug up the ultrasound, then it kind of made more sense. All right, so this one I don't know what to do with. We're never going to get like how you guys would, what we do with this. So this is a 61-year-old who had a lung nodule. Let me get the time frames correct. That had been followed. So I'll show you the nodule. And so it was this guy right here. It has a history of tobacco use, and you got the spiculated lobulated nodule. It looks like a little lung cancer. Was recommended for the appropriate follow-up based on Fleischner, and this was with the new Fleischner, so 2017. And with due diligence, it was followed. And at 2 years, the nodule was deemed to be stable at another hospital. So these were all done elsewhere. And if you look at it, the shape has changed a little bit, but not a whole lot over 2 years. And actually, I went back and ran volumes on these. The volume is exactly the same within the standard error. It looks a little bigger, but not a huge amount of change. It depends on it. So that was, I'm sorry, that would actually, no, I have these backwards. Yeah, this was the original, and this was the follow-up. So if anything, it actually got a little smaller. But for 2 years, no big change. Now show up. Now, patient presents with a big stroke, and the chest CT was done because this mass was picked up on a radiograph, and then we got the outside images transferred to us, and there's this new mass here, and it's right in the expected location of the old one. It can come up right there. So the presumption is this nodule is now this mass, and it's presumably a primary lung cancer. They're not going to do anything to pursue it at this point. A patient had a pretty bad MCA stroke and does not wish to pursue any workup. But my question is you have a nodule that's stable to smaller at 2 years, both with measurements, linear measurements and volumes. I mean, it's acceptable to say, okay, this is presumably not a lung cancer, at least, other than maybe a carcinoid, but it's not an adenocarcinoma or a squame. I don't know what to say when you get these. What do you do? I mean, we typically stop following.
Yeah. There's a finite chance, of course, that
right.
the new lesion that engulfed that thing I know it's in the same place, but
It's very possible.
that was benign, and the other thing just happened to grow in the same part of lung or nearby.
You hear it. So this was the baseline. I'm sorry, I had them out of order. This was the follow-up. So to me, if anything, it kind of contracted a little bit. And here's the second follow-up, and you can see it kind of contracted even more. But I went back and, they're all 1 millimeter or 1.25s. I ran them all through volumetrically, and they're pretty consistent across the board. So I guess, I don't know, it's just one of those ones. Typically the 2-year rule is, it's based on our data. So, but you're right, there's always a small chance that something else engulfed it, or it just decided to grow all of a sudden. Because you would think something this big. So, we're talking only 2 years between this scan and this scan. And it went from stable for 2 years to all of a sudden taking off. So maybe something mutated and it just went off like wildfire.
Yeah, probably.
Yeah.
Those are scary ones for sure.
Yeah. All right, I'll show you guys this one. I think Travis, I can't remember who I sent it to, but I came across this just recently. And this patient has a known history of pulmonary embolism and is on, Apixaban, so one of these new anticoagulants, and presented with this CT and has this huge thrombus, presumably a thrombus. It sure looks like one. I'll put up the sagittal. It's low attenuation, it's very homogeneous. It's adherent to the wall. It was not there 6 months ago. There's a little bit of plaque along that surface, a little bit here. And so at this point, they're actually not going to do anything about it other than keep her on anticoagulation, because to go get this out, the risk of fragmenting this thing and sending it somewhere else is very high. But that's a big thrombus, and it just surprised me. So they're going to work her up for hypercoagulability. But she's 77. It'd be unusual to, present late in life with this unless something changed. And I found out, complicating matters, they think she's developed heparin-induced thrombocytopenia. But
I don't know what to do
it's
for
just
that.
Yeah, it's interesting that it's just along the greater curvature of the aorta rather than the lesser curve where we typically see these. Now, the original echo review where they had a lot of these thoracic aortic thrombi, some of them did occur, a minority along the greater curve.
Yeah.
And the fact that you have a prior from 6 months ago is reassuring that it's not an intimal sarcoma.
Exactly. And she does have a remote history of lymphoma. It sounds like it's in remission. It could always be in the differential, but it is so bland and homogeneous and low attenuation. It would be really unusual. So that was kind of just weird and kind of cool at the same time. All right. And then just one last one. It's just a nice example. I have bronch pictures. So this is a 73-year-old who I came across her because she had a bronch. Let's see, I get the right windows here. And she has these nice filling defects in her trachea. She's a former smoker and just has all these blobs in the trachea here. So nice example of tracheal bronchial papillomatosis. She does not have lung involvement, probably a little bit of microaspiration down there at some point, or just from obstruction. Does not have any squamous cell cancers at this point. So it's presumably HPV related, but I've got a really nice bronch showing these, and you can see these are the tracheal ones. Here's the carina, and you can see all these little squamous papillomas and even the right main bronchus. So they tend to just debride them symptomatically to prevent obstruction and things like that, of course. But she's one of the old, I've seen them in older patients, but almost 80 is kind of, she's 73, I guess, not almost 80, but it's kind of older to be presenting with this. So I don't know if we're going to see more of this as that the HPV positive population ages or what. But I feel like I've seen a lot more in the past 5 years than I've seen in the previous 10 before that.
That is curious.
So anyway, bunch of. All right, guys.
Hey, Jeff, I have one more I can show.
All right.
I want your thoughts on what you guys think, and this is not, well, I don't think it's fibrosing mediastinitis, but the point that Howard brought up, or the finding on the radiograph of your case, and this is kind of interesting. I saw this radiograph earlier this month, and you can see there's this extra contour adjacent to the aortic arch. And I went back, and first I'll show you the radiograph. So this is 10 years ago, and it's been there. Yeah, in the acute setting, you think maybe there could be a dissection or displaced intimal calcification or lymph node or something there, but the fact that it's been there for 20 or for 10 years plus, certainly not. And then this is really interesting because he had a lung cancer screening CT. And so this is a non-con, and you can see that there's all of this, some of it dense calcification or ossification perhaps, and some of it more amorphous. And it really encompasses the entire aorta from just above the sinuses, through the arch. Not only that, you see some of this stuff extending along the arch vessels as well. Got this weird finding involving one of the pulmonary arteries where it looks like the same thing. And then there's a chronic pericardial effusion. Now you'll see that he's also got some renal issues. And this is back a few years ago. He already had abdominal stents and has been diagnosed with retroperitoneal fibrosis in the past. And you can see why he's getting a percutaneous nephrostomy, because his ureter is occluded and his other kidney was already, was chronically obstructed. So my first thought was going to be IgG4 related systemic disease. And apparently they did lots of tests based on the retroperitoneal biopsies they had and did not find an increased number of IgG4 related cells. So long story short, I really don't know what this is. I'm just curious what you guys think.
Well, at first
I thought maybe
it's syphilis, but then with the abdomen, that doesn't quite.
Yeah.
It's like milk of calcium, or a chronic, an old injury or like an old dissection, but that doesn't look right. Erdheim Chester, that doesn't look right.
Right. Yeah. And even if you just had the thoracic stuff, like maybe some sort of burnout vasculitis like Takayasu, but that doesn't, the fact that he's had other systemic things, including all the retroperitoneal stuff, I mean, maybe some sort of granulomatous infection that caused a fibrosing mediastinitis type picture in his abdomen, a retroperitoneal fibrosis, but I don't know. I just thought I've never seen this kind of look encasing or surrounding the arch and the arch vessels. So I thought it was really interesting.
That's a pulmonary artery, or is that a vein that right there?
I think that's an artery. It's right next to that airway, I think.
Same thing to a pulmonary artery. Yeah, that would be, maybe like Takayasu could do that.
Yeah,
that's weird. But
then again, it doesn't tie into the belly. So, well, I'll put this one out there for anyone. If you've seen something like this and have any other thoughts, because I was still, because I was going to chalk this up as IgG4, and then they looked for that and didn't find it. Doesn't mean it's not some sort of related thing, and they just haven't gotten the right tissue to diagnose it. But
yeah, wow,
that is the strangest.
Okay. It's pretty cool.
It's really cool.
So, all right, guys.
Thanks, guys. Talk to you later.
Thank you. Okay.